Welcome to the 8th Annual Seattle Area.
The Seattle Epidemiologic Research and Information Center, in collaboration with the Department of Veterans Affairs, the VA Employee Education System, and the University of Washington Departments of Epidemiology and Biostatistics, presents the 8th Annual Epidemiology, Biostatistics, and Clinical Research Methods Summer Session.
Good morning, everyone. Welcome to the 8th Annual Seattle ERIC Epidemiology, Biostatistics, and Clinical Research Methods Summer Session. The title of today's course is Epidemiologic Aspects of Military Post-Deployment Health Conditions, Natural Disasters, and Terrorism. I'm pleased to be able to introduce to you today Dr. Greg Gray, who's a professor of epidemiology and director of the Center for Emerging Infectious Diseases at the University of Iowa College of Public Health. Dr. Gray is a retired captain in the U.S. Navy and a graduate of the Naval Academy. He has published 32 reports from epidemiologic studies among Gulf War veterans, and he also served as director of the DoD Center for Deployment Health Research while in the military. And today he will talk on epidemiologic aspects of military post-deployment health conditions. Dr. Gray.
Well, thank you, Ed, and good afternoon, everyone. What I'd like to do today is talk to you about a portion of the spectrum of illnesses that were examined with respect to Gulf War veterans. If you've been with us for the other talks in this series, you'll note that we've already discussed outbreak investigations, health registry case series, symptom studies, and aggregations of symptoms using statistical means. So today we're going to look at healthcare utilization and examine in an overview some of those studies. Let me again remind you that the spectrum of alleged morbidity that has been examined thus far among Gulf War veterans is quite broad, and most of the differences that have been seen have been in the left quadrant here, or the left sector, in the mild illness. And so today we're going to look at things that caused people to be ill enough to be sent to the hospital for rather intensive medical evaluations. Well, the healthcare utilization studies can be broken up into a number of different categories. These are the constructs that I developed. We have hospitalization studies and outpatient studies. Among the hospitalization studies, we have those that were conducted using Department of Defense data, and those that were conducted using Department of Veterans Affairs data. Note that both of these data sets were administrative in their nature and not really designed for conducting epidemiologic studies, so they have some limitations. In addition, one of the studies used a similar electronic database that was maintained by California, and this is not every civilian hospital in California, but a number of them. And finally, there were some studies of some electronic and paper records in a large hospital in Saudi Arabia where some of the servicemen were sent, as well as some data that were examined regarding hospitalizations in the Gulf War theater. With respect to outpatient studies, the Department of Defense and Department of Veterans Affairs did not have really good outpatient data that could be examined for the Gulf War veterans, because most of their databases didn't come online till well after the veterans had ceased to participate in the war. In a similar fashion, there were some paper records that have been examined from the Gulf War veterans that were seen as outpatients in the theater. Those have also been reported in the literature, but we won't chat much about those today. Well, you might ask, well, how many of these studies were controlled? I mean, how many of these did the investigators have a control population from which to compare the morbidity? And the ones that were controlled are shown here in yellow, quite a few of those, and we will focus on a number of those today. Well, let me just ask the audience here, many of you are epidemiologists, What challenges might you face in conducting epidemiologic studies of Gulf War veteran healthcare utilization? I wonder what the audience thinks.
I would imagine that one of the challenges would be getting a representative sample of the Gulf War vets that use the actual healthcare systems during that time.
Okay, so sampling issues, very good.
Also, where the veterans or the military actually get their health care, if they're still active military, they would be covered by the Department of Defense and Walter Reed. But if they've transitioned into the VA, then they enter a completely different database, and you have to get the data from the VA.
Okay, and not everyone is eligible forever for VA medical care. Good point. So access to care is a question. What other sorts of issues do you think you'd wrestle with?
I would wrestle with wanting to know what the underlying rate of hospitalization would have been had they not served in the war.
Okay, okay, good. So baseline data, independent of deployment. What do we know about the drawdown in the military after the deployment? What happened after the soldiers went to the war? Anybody know?
What's drawdown mean?
Okay, good question. What does drawdown mean? After the conflict ended, there was an abrupt deployment home of the servicemen, with many of the servicemen leaving the service, and a drawdown in the force of the military through various different means. The thinking was we didn't need so many people in the military. So epidemiologically, that's a problem in the sense that if you're no longer on active duty and we're not actively following you, you may have a hospitalization or a healthcare visit in a civilian sector that might not be catchable. And it also might be very difficult to find you if you're a young person with a really transient address to survey or whatever to find out your morbidity. And what other things do we know about with respect to the media that might influence the healthcare utilization? And what other things happen to the veterans? Well, remember that there was a tremendous interest by the media in the alleged morbidity, and there were also the multiple registry programs that were stood up. In some of those settings, the inpatient and outpatient encounters were captured electronically. And so you could basically have someone that was hospitalized for administrative purposes that could confound your results simply because of their exposure. Well, here's a few of the things that we encountered in conducting these studies. Data on the Reserve Guard personnel are incompletely captured in the DoD healthcare systems, and probably incompletely captured in the VA systems because of if you had, for instance, a setting where you were in rural America and your health care was much easier to obtain through your current civilian employer at a local hospital or a local doctor's office, all that medical encounter data would likely be missed by the Department of Veterans Affairs or the DoD because we wouldn't have access to those electronic or paper records. We know that it would be very difficult to study in-theater hospitalizations, and there were multiple mobile hospitals in theater because most of the records were not electronic, and because the paper records, it's hard to aggregate those and study those systematically. What about, who knows about ICD-9 codes? Okay, who can tell us some of the problems about analyzing ICD-9 codes? Okay. You guys have done that. You're intimate with ICD-9 codes. Okay.
One of the problems we've run into is There are some diagnoses that, even if criteria are met, they're less likely to be used.
Okay. And why is that? Is it why do the people not like to use some diagnoses?
Certainly in the military setting, the stigma associated with some diagnoses is such that physicians may be less likely to use them, or alternatively, they may view it in the soldier's best interest to not use those diagnoses.
Okay, real good. Excellent point. Well, did anyone else have another comment about ICD-9 codes? How many, go over here.
Having spent a fair amount of time wandering through ICD-9 codes, you find that certain specialties or subspecialties tend to focus in on varying degrees of specificity in ICD-9 codes, and others will just sort of put it into the .00 category of just generally that particular diagnosis.
Very
So
good.
that makes it difficult to examine.
Great. So biases with respect to your personal medical training. That's very true. I think that's been well documented.
One other issue is, I think that's relevant for Persian Gulf War. That is the category of signs and symptoms is very broad and vague. So a lot of people would probably have been coded in this category, and you can't really tell whether they're being coded for fatigue or some other kind of symptom that's not associated with a disease per se.
Excellent. Excellent comment. Very true. Very true. Well, there are thousands of these diagnoses. As epidemiologists, often we look for ways to reduce data. We call this data reduction strategies. How might you reduce these thousands of diagnostic codes and perform some sort of systematic comparison of the post-war hospitalizations?
Well, the ARC clinical classification system, the CCS coding, aggregates the ICD-9 codes into 245 or whatever categories, grouping around particular organ systems, and that helps a little bit pull things together.
Okay. So some predetermined administrative categorization of the diagnostic codes. What happens when we start looking at dozens of outcomes in an epidemiologic study? What are we concerned about? Okay, power, that's right. But another thing that's very common, we say the problem of multiple comparisons. And there's a great debate in the literature about how much we consider this. But statistically, if we're looking at a certain confidence interval that involves random effects by chance, if you look at enough outcomes, statistically, you should have some of those outcomes that occurred by chance alone. And so it's very important. One of the arguments in not adjusting for that is to simply look at the effect size of the finding. In other words, is the odds ratio or the risk ratio really high, then don't worry about it so much. Or if it's marginal, like just a little over 1 or something, maybe you could say that this could have occurred by chance. Anyway, the problem of multiple outcomes, it was a very real one in analyzing the healthcare utilization data because the alleged morbidity was very, very broad. It wasn't very specific. It wasn't just a few diseases. We also have something called a healthy worker effect. Now, how many of you know that term and could explain that? Somebody could explain that to us briefly? Okay. Why would we see some people deployed to the Gulf War as having better health than perhaps their peers? Okay.
If you weren't in good health, you probably wouldn't be deployed. You wouldn't be allowed to be deployed.
Okay, very good. So if you had suddenly an acute illness that incapacitated you, such as a fractured leg, it wouldn't cause you to be discharged, but nevertheless, you might not be deployed with your unit, and therefore that must be taken into account. What about if there's a new novel illness? Let's think, for instance, of some of the emerging infectious diseases that are unlike any before. Legionnaire's disease, I think of avian flu. How would they be coded in the ICD-9 coding system that we use administratively for healthcare utilization?
It would be under other.
Okay. Okay, so it would be under other, and it's not real clear. So when you have a new, in a way, looking at these data for a new entity, a new associated illness, using old traditional codes, you got to ask yourself, well, how would it be coded? And how would you look for it? So those are some of the issues that faced epidemiologists. We had this wonderful repository of pretty darn complete data collected for administrative purposes, but a lot of limitations in how you could use these data. Well, I want to walk you through some of the studies. The first study was one that our group published in the New England Journal, and we examined a cohort of active duty personnel, 547 regular active duty, not reserve or guard, who were deployed, and 618 non-deployed personnel, regular active duty as well. We stratified into natural groupings the various outcomes. We didn't have a 240-some categorization. We used this one that came with the ICD-9 code book, 17 categories, and any cause hospitalization. Because we had the problem with the departure from active duty of many of the veterans, we initially only looked at a short period of time after the war. So most of the veterans were back from the theater by August the 1st, 91. We decided to look until September the 30th, 1993. Now this study has a number of limitations, some of which we discussed earlier. We couldn't examine people who had separated from the military. So if they separated with a medical problem, perhaps the cause of their separation, we would not detect it. And these data are limited to people that were hospitalized, so they had to be sick enough to get through the gates of the hospital systems. Now, we were able to marry the electronic hospitalization record with demographic data from the personnel records and able to look at a number of different demographic, healthcare utilization, occupational risk factors, some of which proved to be very important into the multivariable modeling. In these early studies, we did not have access to enough software power to do another type of analysis that one might consider more appropriate. Does anyone have an idea of that other than logistic regression type of analysis that we might pursue? Another multivariable technique. Sorry?
You're talking about GEE?
No, not. I'm talking about longitudinal following a cohort and using something like Cox proportional hazard modeling. So basically, we took thin little slices of time and we looked for an outcome in those slices of time. I think we did 3. Another approach, and one that we followed after we had better software, was Cox proportional hazard modeling, where you can factor in entry and exit of a person from the cohort. Well, it's a rather long and complicated story, but the results are shown here for the any-cause hospitalizations. And you'll note the very, very tight confidence intervals. So we had an odds ratio that included 1 for all 3 of the periods that we examined. So that tells us that adjusting for a number of different covariates, there was no evidence of increased hospitalization risk for those veterans who had been deployed to the Gulf War compared to their non-deployed counterparts. Here are the 17 different ICD-9 classification categories, and we looked at each one of these. Now, in the DoD system, you could have diagnoses, up to 8 different diagnoses for one clinical encounter. So we had to build an array system to say if a person has any of these 8 diagnostic codes, or in any of those fields, a diagnostic code of this range, they would count as having an outcome. In a similar fashion, we had to evaluate, in some cases, multiple hospital admissions. And so you would have to search during that time period for multiple admissions and multiple diagnostic codes. A little graphic depiction of the type of data are shown here. And we had these analyses for each of the 17 different categories, as well as the any-cause hospitalization. What you can see here is there's something going on in the first time period with respect to neoplasmas, and something going on in diseases of blood in the second time period, suggesting that the Gulf War veterans are at increased risk of hospitalization diagnoses in those categories. So what we did next was then examine the 10 most frequent diagnoses in the categories of interest. And there were 4 or 5 of these that had some sort of finding. Remember that when you have this many thousands of records and people in your model, you have tremendous power to ascertain a difference. Very, very powerful. So just a handful of people could make a difference. What we found in looking at the neoplasmas, it was the top 5 are only shown here, but no real difference in the top 5. There was a slight increased risk for veterans having testicular cancer. So we examined that risk and found that it was only for the first time period and that it was likely due to deferred health care. In other words, the veterans would come back having noticed a nodule or something in their testicles and not want to take care of it in the field because there were not as readily access to care. But when they came back, they got it cared for, and hence the little blip, a one-time blip. Nevertheless, that little indication led to its own independent study, actually a couple studies looking at testicular cancer, as it is one of the most frequent cancers for healthy young men, otherwise healthy young men. And suffice it to say, there was no indication of risk. With respect to blood disorders, we were really excited. We thought we found something here. When we ran the frequencies, the most common things were associated with anemias. What do you think might explain the anemias? I'm sorry? Women, okay. Menstruation, okay. What do you think happened right after the veteran? Remember, a lot of women went over to the theater. What happened right after the women came back? Yeah, they all got pregnant. So there was a post-war baby boom. And in the second phase, if you look at the graphs, that's right about right. So they got pregnant, and this is an anemia of pregnancy. When you take out the diagnostic codes, as we did, that were related to pregnancy, and you adjust for those, it all goes away. So we found these things. We're all excited, and to make a long story short, no indications of that we didn't of diagnoses that we didn't understand. In other words, pregnancies we understand, deferred care we understand. There were increased post-war risk of mental health hospitalizations, which is consistent with the literature. Here you see the attrition by quarter with a lot of people leaving the military after the war. But no great exodus of Gulf War veterans compared to non-deployed veterans. So in our summary of this paper, which is an example of the other papers I'll talk about, we found through multivariate logistic regression modeling for any cause in 14 hospital diagnostic categories, I think it's 17 really, over 3 post-war periods, they were increased risk for 5 of the 45 models, but risks were not consistent over time and could be explained by deferred medical care, a baby boom, and conditions known to be associated with war. So we really didn't find anything for the first 2 years after the war. Well, how would you search for evidence of a new disorder, one that had no diagnostic code?
You would just look for an increased incidence in the usage of a common diagnostic code or something that's not otherwise specified.
Okay.
And then look into that.
So you'd ask yourself, what codes would people most likely use, the sort of catch-all codes? Well, we were fortunate in that that's exactly what another group had done. They had, for the purposes of examining deaths due to an unusual condition, a CDC group several months before this study had identified ICD-9 codes most likely to catch novel illnesses. So we basically did a similar type of analysis using cost proportional hazard modeling, and we looked at these 77 diagnostic codes thought to best describe unexplained illnesses. Again, looking at Department of Active Duty personnel, a little further out this time, up to 96. These are the 77 diagnoses that were published in a paper several years before our effort, and you'll see if you can read them that they're all pretty much non-specific. Unspecified zoonotic bacterial disease, gastroenteritis, unspecified protozoal disease, etc., etc. So thought to be a good catchment. So we conducted an analysis using those in the aggregate, and voila, we found it. We found evidence of a Gulf War syndrome, or so we thought. We found an odds ratio for at 1.06. It is independent of 1, increased risk for the Gulf War veterans. We're all excited. We found something real instead of a negative study. But when we look closer, we found that in examining some of these hospitalizations, temporarily we found this little blip here. So the deployed veterans, over time, suddenly they're running along after the war, and suddenly there's an increase in hospitalization probability. What do you think might have happened right about here? Somebody say? Okay, media, well, that's one thing. But actually the media was happening before this time.
They're getting ready to retire.
Okay, big surge of retirement. No, we didn't have evidence of mass exodus. Well, this is the time of the DoD's registry startup. So this is the CCEP is now being promoted and advertised, and it turns out that when you look at the people that were hospitalized and you compare them with the registry data, among the Gulf War veterans, a high proportion were being admitted for administrative purposes. And so we did some analyses, having pulled out the people, a small portion of the people that were sent to the registry, and we examined some paper records, and sure enough, it was all artifactual based on the registry participation. So we were, again, with a null study, a negative study. A little disappointing because in epidemiology you like to find positive associations or something that we could put our hands around, but still a negative study. Well, what if the sickest Gulf War veterans left military service before being hospitalized? How might we find them?
Look at the VA.
Excellent. Look at the VA system. Where else might they go besides the VA hospitals?
I just wondered if you also looked at the people that were being medically boarded.
We did not in this study because I'm not sure why we didn't. If the medical board is sort of an entity that independent of hospitalization. It may be associated with hospitalization for evaluation, but anyway, we didn't examine that directly. What else might you do, though? What other kind of data do you think that, come on, you're really an aggressive epidemiologist, and you want to get to the civilian sector data. How would you approach it?
For Medicare, Medicaid if they were that sick.
Okay. We didn't chase that, but that's a good thought. I suspect that's not often done for the the people of this age bracket, but that's a good thought. Well, what you'd probably try to do is, I'll just go ahead and cut to the chase. What you probably want to do is find an area where you think there are a lot of military personnel, home-based, both civilian and military, and look for a civilian hospital system that has electronic data that you could get. And so that's exactly what we did. We worked together with the Department of Veterans Affairs and similar epidemiologists in a California hospitalization system, and as best we could, realizing that the systems are all different and they don't actually mesh together, we aggregated the data. We sent them Social Security numbers, they ran them in their systems, they sent us encounters for hospitalizations, and while we don't have good denominators, because we don't know in the VA or the California systems who was eligible to care, for care, we were able to look at proportional morbidity ratios. And in this study, we found no indications that Gulf War veterans were suffering increased proportional morbidity ratios for infectious diseases, neoplasmas, endocrine diseases, blood diseases, etc., etc. However, we did find more hospitalizations for fractures in bones and soft tissue injuries. These were DoD data. For various diseases of the respiratory and digestive systems at the VA, and diverse symptom diagnoses at the VA. And this was 91 to 94. Well, what about the specific exposures that were alleged with the Gulf War? We talked a little bit about this in an earlier session. How might you conduct healthcare utilization data studies based on those exposure data, or those alleged exposures? Okay. Remember that there were many exposures in the Gulf War theater that the veterans were concerned about. Taking of medications, receipt of vaccines, being exposed to oil well smoke, being exposed to heater petroleum products, being exposed to sand flies and some of the sand fly-borne diseases. So if you wanted to hone in, so what we've done so far is discuss epidemiologic studies that were very broad. If you wanted to hone in on a subset of Gulf War veterans who had specific exposures, how might you do that?
If it were possible, what I would do would be to hone in and try to form a cohort of the people of the military that were exposed to one specific exposure, or sometimes you can get that if they were operation specific. So people going into those particular type of arenas that have specific exposures, and then follow them and see how the use was different.
Okay, excellent idea. Well, that's exactly what we did in a couple cases, and maybe I'll just show you that. Remember that there was an incident several months after, or at a short period of time after, weeks, I think it's like 7-8 days, after the fighting had ceased, where our military forces were destroying munitions that were stored at a place called Camisea. The event of interest occurred on 10th of March, and rockets in an open pit were probably contained the nerve agent sarin and cyclosarin. This was learned publicly, if you will, some years later. This is a depiction of a diagram and a photograph of the bunker that was implicated, that had some of the sarin-containing rockets up this top panel up here, and then down here was there was a pit. So quite a few of these that they destroyed. This is a diagram of the pit with the stacks of rockets. And this is the after the demolition views of the site. Well, there weren't a lot of good environmental data that were captured subsequent to those demolitions. But the Department of Defense interviewed many of the people retrospectively that were involved There were a lot of modeling exercises conducted. This is all recorded in reports in GulfLink. The questions that people were asked to examine: what is your best estimate of what was destroyed, how was it dispersed, and who was exposed? There was intensive modeling conducted in the desert with simulants to try to get an idea of how much sarin and cyclosarin would be around having had the munitions destroyed. And so they tried to, as best they could, set up models and to see the dispersion effects. What they determined was that a very, very small proportion of the agents would have been dispersed by the means of the munitions destruction. Some spilled on soil, some on wood, some aerosolized, etc. So a bunch of experts from various different disciplines got together and examined these data and constructed a plume, a geographical modeling system based in and around Camisea that was a product of meteorologic data, troop movement data, and the simulations. And they notified a number of veterans that potentially in early '97 you were under this plume. Now what do you think happened when they notified those veterans? You can imagine there was a lot of concern, a lot of media interest, and the participation in the health registries escalated. The estimates put together by the experts were very, very conservative. It's complicated, and it involves a field that I'm not real well trained in, but the toxicology in nerve agents is illustrated by a number of different cut points. We have something that we're all too familiar with, and you'll hear more about from the sarin incident in Tokyo later on in this course. The lethal dose being rather high, and incapacitating dose being a step down, and then something called the first noticeable effects dose, where you just have some mild symptoms, but you wouldn't really know if this is due to a nerve agent or not. And then a general population limit where the CDC would say even long-term exposure would not create any adverse effects. So this first noticeable effects limit, that was sort of the cut point they used in the modeling. Here are the diagrams for the modeling. We have initially a rather gross, if you will, or very, very conservative model constructed here with the blue hatches over the 4-day period. And this was the notification plume. The units are marked here in dark. These are the military units that were under these plumes. So if you belong to a unit, whether or not you were under that plume geographically or on another mission, you were notified. And you can see that there were quite a few units under the notification footprint. However, further analyses some months later better defined the epidemiological footprint, and this is again the analyses of many experts in meteorology and the toxicology that constructed this. And it's the epidemiological footprint that we've used in the modeling, and so it's in lavender here. And there's even a subsequent refinement of that that we'll hear about in a bit. So we did a similar DoD healthcare utilization study of hospitalizations as we've done before, looking only at the active duty personnel, and we examined their hospitalizations up to September '95. We divided the exposures into 3 different categories, actually 4: uncertain low dose, exposure 1, exposure 2, and exposure 3. These were the products of exposure over time, and they were constructed by toxicologists who factored in dose and length of exposure. We again looked at the ICD-9 categories, and we found a slight increase here for mental disorders and a protective effect for endocrine, nutritional, and metabolic disorders. When you examine the mental disorders, they're consistent with PTSD and other things that we knew before the veterans were at increased risk for. So nothing really surprising. We asked a body of experts, the Armed Forces Epidemiological Board, to review the medical literature and propose ICD-9 codes that they thought would be most likely the resultant diagnoses for a sort of a subclinical effect of a nerve agent. In other words, what sort of manifestations, atypical manifestations, might one see chronically? Although there is no evidence of this in the literature. Usually a nerve agent has an acute effect and that's it. There are some animal models, though, and some epidemiologic studies that they're not real strong, but suggest there might be an effect. And so we asked the experts for those diagnostic codes, and here are some of them. We looked at these in the aggregate as well as stratified by them and found no increased risk for those veterans that were under the epidemiologic plumes. So these data did not support the hypothesis that Gulf War veterans are suffering post-mortem morbidity from subclinical nerve agent exposure. Now, the plumes were again revised after more experts examined them, and a further study conducted some time later went all the way out to 2000, so another 4 or 5 more years. Tremendous power to examine those that remain on active duty. And they did found one diagnosis that was slightly at increased risk, cardiac dysarrhythmias. And so that is about the only association that has come from these studies. It's not, as far as we know, been found in other groups. Of course, not other groups were under the plumes, so it's hard to know what to make of this. Did it occur by chance through multiple comparisons, or is it real? Well, there are multiple other studies that we don't have, hospitalization studies we don't have time to cover, but again, these were reviewed in the recent review issue of the Transactions of the Royal Society, Journal B, in April of 2006. And there's even some work that is in press showing, comparing Gulf War veterans' hospitalizations with those U.S. veterans deployed to Asia and Bosnia. There were a number of outpatient studies performed. In general, the war zone data for outpatients were very poor in paper format and thought to be very incomplete. The quality of the outpatient data were not captured electronically until 96 for the VA and 99 for the DoD. So for this conflict, we really don't have good outpatient data, but we will and we do for the veterans returning from Iraq and from Afghanistan in recent years. So most of the reports are essentially case series, paper-based data. There's some evidence that Gulf War veterans, considerable evidence, Gulf War veterans experienced increased clinical encounters due to respiratory disease and enteric diseases during the theater that seems to be explained by purchasing a number of different vegetables in the markets there in the Middle East. There's also some evidence from a small subset of patients studied outpatient-wise of orthopedic problems, respiratory complaints, and dermatological conditions being the most prevalent, but it's hard to know what to make of this because there's not a good comparison group of non-deployed personnel. In similar reviews of the case series, if you will, respiratory illnesses and injuries were common. Ambulatory care after the Gulf War studies are really tough because of the lack of electronic data. There have been some attempted, particularly at different hospitals where the records are available, but again, it's a subset of the entire cohort that was deployed. There is some suggestion of increased mental illness disorders, There is one study that suggests, possibly two, an increased risk from Lou Gehrig's disease, amyotrophic lateral sclerosis. I think this is being followed intensely by the VA because of the expected long latency of any exposures, and it's easy captured as it often leads to death. So this will be re-examined over time. There has been a study of an alleged birth defect called Goldenhar syndrome that was equivocable, done by our group. But nevertheless, there have been some attempts to look at ambulatory care data, although they're not really too convincing. So let me summarize here. The Gulf War veteran health problems have not manifested in unusual causes of hospitalizations that might indicate a new Gulf War specific condition. From healthcare studies, we can expect future veterans to be at increased risk for mental health disorders, multiple symptom conditions, accident-related injuries, and musculoskeletal disorders. And I think we're certainly seeing the mental health conditions and accident-related conditions with the returning veterans from Iraq now and Afghanistan. And while there were some interesting findings, cardiac dysrhythmias, ALS, mental disorders, and cancer mortality, it's a little bit hard to argue that those things are strong and real, but they merit continued follow-up in the Gulf War veterans. Certainly cancers, the further we get out, many cancers with a known exposure have quite a long latency period before they manifest, and so it's good to look at cancers and mortality. Well, I think that's all I have on this lecture. I want to thank you for your kind attention in our review of the Gulf War veteran healthcare utilization data.